As I was saying, we have a very special guest today, and her name is Sajeda. And so she is going to be talking about her life as a medical student and how she transitioned from A levels to her university. And obviously, she has a current interest in ophthalmology. So I'm sure she'll tell you all about it. And after that, we'll be doing a quiz, which will be interactive. And so we will be expecting some engagement in the chat, or if you want, you can open your mics and just speak at us and we'll give you feedback. All right. Yeah, I'll hand over to Sajida now.
Okay. Hello, everyone. So yeah, as Serena mentioned, I am Sajeda. I am a third year medical student at the Brighton and Sussex Med School. And yeah, kind of the reason why I wanted to give this talk on this specific topic is because I feel like when applying to med school or a lot of people kind of, you know, they may not know too much about what it's actually like being a medical student because you put so much effort and work into actually getting there. So I thought, yeah, I'd kind of let you guys know what it's like. So just for some background. So yeah, today we're going to talk a little bit about me, my journey, how it was transitioning from A levels to medicine, and then kind of yeah, what medical school looks like for me from year one till now, and then kind of reflecting on what's good and what's bad about med school because obviously it's not all amazing and it's not all bad either. So yeah, if we could go to the next slide, please. Yeah, so just a little bit of background about me, so yeah, like I mentioned, I'm a third year medical student. Um, I grew up in Northwest London. Um, I went into medical school straight from A levels. Um, and yeah, I did biology, chemistry, maths, as most people applying to med do. And actually, I didn't want to do medicine until I got my GCSE results. I was interested in studying either architecture, computer science, or something politics related. Um, I thought it would be too kind of like stereotypical for me to do med because I felt like everyone expected me to do that. But I ended up um, deciding that I did want to pursue it. I also really like to read. I like painting, drawing, and I'm really into fashion as well. Um, I wouldn't describe myself as super studious, but I always loved getting involved in societies, extracurriculars, and I think that really helped me kind of get into med school and get to where I am today. Um, yeah, yeah. So my journey, I know that as fire medics, like the most important thing some people look for is the stats. So here are mine. I was predicted 3 stars, and I did quite well in my APQ. My UCAT was okay. I know it's slightly different now because they've removed one of the sections. My BMI, don't actually remember what I got, but I think it was something like this. And I was one of those people who was like really, really set on going to Cambridge. Like for some reason, I thought that it was either Cambridge or nothing. Um, so BSMS, my current university, I only applied to because I didn't know what else to put down, and my friends and I had gone to an open day at BSMS, kind of just for fun because we wanted to see Brighton. And I thought, you know what, why not? Let me just put it down. Um, to kind of aid my application, I'd done some work experience in ENT in East London. I'd done some volunteering as well. And like I mentioned, I did a lot of extracurriculars. Um, yeah, go to the next slide, please. So yeah, what happened? Cambridge, I got an interview, nice, and then I got rejected. Got rejected from Nottingham, KCL, and then BSMS gave me an interview and an offer. But obviously, because I was so set on going to a more selective university, I wasn't like too happy. I was very close to taking a gap year and not going at all, but I decided med school was med school. So I accepted the offer and became a first year at BSMS. So what was that like? So September 2023 was my first day of medical school. Um, I'm from East Northwest London, so I wasn't going to commute. I moved out and it was quite daunting for me initially moving out. I was excited to be honest, but also, you know, being away from everything that you know, from family. from friends, a whole different city where everything works differently. It was really daunting at first. And making new friends, I think because like, as you go through school, you kind of have your group of friends and you're used to them. Just suddenly being in a new environment where you're going to be for the next few years and then having to make friends was also a little bit daunting. But the main thing that was new to me was was how I was going to approach medical school. I didn't know if my A-level study methods would hold up, if I could kind of continue the same. Sorry, I'm just going to take a drink. So yeah, I didn't know if I could use the same study methods. I didn't know what it was going to be like. So got through freshers, had a fun freshers week, and then year one officially started. So if we could go, sorry, to the next slide. Yeah, so I went from sixth form where I went to the sixth form where we had very little like actual contract hours. We had a lot of free periods. It was very independent, which might have helped to suddenly having lectures. And obviously I'd never been like in a lecture before. So lectures, the first one, it literally just felt like it was in a different language. Like I did not know what was happening. I started taking notes and literally I could see around the room, everyone was just closing their laptops, closing their notebooks. Nobody knew what was happening. And I suddenly felt really, really out of my depth. Like, because we had, you go from everybody, when you, on your first day of medical school, you know that everybody in the room, they were all the smartest in their school. They were all the best top students. And now suddenly you're all here just like, oh my God. Excuse me, guys. You suddenly feel so out of your depth. And that's actually very normal because one, professors kind of do that on purpose. And two, it's medical school. You're not in sixth form anymore. But I actually found that as time went on, it was actually not too big of a jump compared to what I expected. I'd say especially the first term of year one, it was actually quite a similar level. It was quite a similar level to sixth form. And I think once you start making friends and everything, it was actually quite nice. So yeah, most of year one for me was lectures. So we had lectures every single day apart from Thursdays, where we went off to the other side of campus and had clinical activities. So taking histories, doing examinations, clinical skills like taking blood pressures. That's what we do. So once a week we'd have clinical stuff, and the rest of the week was just pure just lectures. And we also had this thing called SSC, which you guys might have heard of, where the student selected components, where essentially it's completely random topics. There's art ones, there's tech ones, there's medical ones. And it's like for 1 hour a week, you do that, and then you create like a presentation or an essay about it at the end. So I did some on programming, some art ones. So yeah, that all of first year, very much lecture based. And then second year. So second year, we'd all kind of settled in. We knew the city really well. So I'd say for me, it was the most fun year so far. Everybody moves off campus in our uni, so everyone lives with their friends, but it's very much still lecture focused. So it's still lectures every single day and clinical skills like once a week. So once a week you spend doing clinical stuff, and then the rest is just lectures. And second year, for me personally, I feel like the jump from first year to second year was a much, much bigger jump than from A levels to year one. A levels to year one, I think, was a lot more manageable. But I think going from first year to second year, in terms of the level of content, was really difficult. Sorry. And I think the reason it's difficult is not necessarily the actual difficulty of content. I think in medical school, a big misconception is that it's really, really difficult. But I think a lot of people think that it's just the content that's difficult. I don't actually think so. I think the content's actually not that hard to understand. It's just the sheer amount of stuff that you have to remember. And second year is really when this hit. And I was like, oh my God, there is so much we have to know. So I'll kind of go over like how I managed that towards the end. But yeah, sixth form was very fun year. Got to do a lot of things, kind of outside of academics, but also it's when I really felt kind of, okay, I'm a medical student. But yeah, and then third year. So I'm currently in third year, and in our medical school, this is the start of clinical placements. And third year truly, like being in third year has made me completely forget about year one and year two because we only have lectures once a week and then the rest is just placement. So we have three major rotations. We have um, medicine, surgery, and elderly and psychiatry. So I did my medicine rotation, so cardiology, renal, rest, and currently I'm on surgery. As you can see, we've got some pictures. And for me, I'm someone who prefers the clinical side of medicine. So I've really, really been enjoying medicine. I go in usually, if I'm going for a ward round, I go in eight for an 8 a.m. or 9 a.m. ward round, um, and then go to see some surgeries, maybe do a clinic in the afternoon. But it's very much you have a lot more independence as a medical student. You know, you go talk to patients, take histories, examine. You go to surgeries. Sometimes they let you scrub in, and you can actually help. Well, very minimal help, but you can actually do stuff. And it truly feels like this is what I came to medical school for. Um, it's really enjoyable. Like I actually feel like putting your knowledge to use. And I personally feel like all the stuff you learn in year one and year two, you can actually now see it in real patients and you can see it coming to life. And when you take histories and when you talk to patients, you can actually see, oh, wait, I'm asking this question because of this thing that I learned in first year and second year, and I can see in this patient. And it's so, so nice to see everything starting to come together. Um, I also feel like I have a lot more of a balance in third year because I have a lot more free time. I feel like I'm a lot more independent. I can kind of really decide, you know, what's useful for me, what extra things I need to do. Um, and on third year, because of placement, we there is also a chance of us being sent on regionals, which is where we're sent to different cities for a term to do our placement there. So I've been in Brighton, which is where my where I'm located for university. I've been in Brighton for the past 2 terms, but actually next term I'm going to a city called Hastings, and I'm going to be there for my elderly and psychiatry rotation. So it's really nice. You get to go to different cities, you get to, interact with patients, doctors, and really kind of, it almost feels like, it feels like one step closer to being a doctor. Um, so I've really been enjoying it. And I think this is probably a good place to talk about my interest in ophthalmology. So I'm very, very interested in ophthalmology. And the interest kind of started, one, because I find that the eyes are really cool. But another thing is um, I really I like surgery, but I'm not a huge fan of like opening people up surgery. Um, I like stuff that's like very kind of like contained, neat, like, and so that's why I really like ophthalmology. I also like specialties that are a mix of both medicine and surgery, which is another thing that drew me to it. Um, I like the fact that, there's a lot of clinics and just sitting down with patients, but then there's also opportunities for surgery, like cataract surgery and, um, you know, eyelid surgery. So that's where my interest kind of stems from. And the good thing about third year is because you have a lot more independence in terms of your timetable. You have a lot more like interactions with doctors. It's so much easier to get exposure to specialties that you're interested in, even if that's not something that you're currently on rotation for. You can email, reach out to consultants, to doctors, ask for opportunities to shadow, and really kind of be exposed to all these things that you might be interested in. Um, so yeah, that's what third year has been like so far. Um, in terms of like exams, in our medical school, we have an OSCE in second year and every year onwards. And then we have kind of KTs, which is like our knowledge test at the end of every year as well. So apart from exam season, all the other seasons, I say they're quite relaxed, quite nice. Yeah. So moving on to the next bit. So the future, what will the rest of medical school look like? So next year in fourth year, it will be very similar from what I've heard. I can't guarantee anything. Like I'm not for sure, but I've heard that it's very similar to third year, but a bit more intense. And then fifth year, well, the current fifth years in our school have just finished their exams. So they're done. So there's actually not much longer left. But I think third year to fifth year is just really nice, kind of being on placement, kind of being exposed to real like clinical medicine. Um, and yeah, I talked about after med school. Obviously, I think everybody here knows, you do your foundation training and then you apply to specialty training, which obviously it sounds very straightforward saying it like that, but you guys might know what it's like, kind of, it's quite competitive actually getting into those training posts. But that's all stuff that you can kind of prepare for to some extent during med school as well. Yeah, and then moving on. Okay. And I think this part is like the most important part of my talk. I kind of rambled on a bit about med school, but the most important part is the good and the bad. So there's this one thing that some of my friends kind of make fun of me for. I love talking about this limiting factors curve. So this curve that I've drawn really badly here in the corner, for me, this is the best way to kind of describe how to do well in med school. So if we look, the axis at the bottom for me represents kind of time spent studying, or yeah, time spent studying. And the other axis, I forgot y and x, I think the y-axis represents your grades or the results. So for me, I'm someone who firmly believes that there's only so much studying you need to do to get to a certain place. So if you're aiming for a pass, there's only so much studying you need to do. And beyond that, you're doing additional stuff. Maybe a waste of time, maybe not for you. But as in, there's only so much you need to do well in medical school. And aside from that, you can actually just, enjoy yourself and have fun. Because at the end of the day, this is still university. You are still a student. You're not expected to be perfect or amazing. You're not supposed to dedicate every single hour of your life to medicine. And once you start working, you're probably going to have less free time anyway. So better to use this time. So the main thing, the thing that actually makes medicine hard, like I mentioned before, is the sheer amount of stuff you have to know. There's a lot of content, like there's a lot of stuff you need to know. There's a lot of content, but the content itself, I wouldn't say is too difficult to grasp. So having a good balance, making sure you don't get burnt out, and starting early is like the number one things that will help you to kind of maintain like the level that you need to in medical school. And yeah, it's very important to have a balance, not to go too far in one direction or the other, because you want to kind of be the best version of you to make sure that you can make the most out of medical school, you can learn the best, and then be an amazing doctor as well. The one thing that is kind of bad about medical school, which doesn't affect me too much, but some other people really struggle with it, is the isolation from non-medics. And this isn't necessarily true for all medical schools, but it's especially true for my one, because some of you, I don't know how many of you know about BSMS. So BSMS is a joint medical school between two universities, between Brighton Uni and Sussex Uni. And because it's a joint uni, we're technically part of both universities, but it also kind of means that we're almost like a standalone medical school. So all of our societies are BSMS societies, so it's just for medical students. Our com, just medical students living in those places. Our timetables, and this is the bit that applies to all medical students, your timetables will be a lot different to people on other courses. Your schedules will be, and at one point, especially once you start getting to placement, you realize that all you ever talk about is medicine, and all you ever talk about is placement and med school. And so other people start to get a little bit bored of you. So there is this aspect of being isolated from people who don't study medicine and being constantly surrounded by people who are also medics. And yeah, like I mentioned, it's not something that I struggle with too much, but there have been people who've, really have struggled with that. And it does become harder to keep up with friends outside of medicine. But obviously, that's not true for everyone. If you can definitely do that. The antisocial hours, this actually isn't really too much of a problem during med school. Like, as in, it doesn't have to be. for some reason it does become a really big problem during med school because I don't know what it is about medical students and studying like at like crazy hours of the night because you totally can if you want, have like a very good balance. You don't have to be pulling all-nighters if you keep on top of it. But I don't know if it's because we're all last minute people or what. But at any point, like especially near exam season, if you go to the library after midnight, I can guarantee you'll find a bunch of medical students there. So I guess that's one thing. Um, and then obviously there's all the stuff on the news about, specialty posts and pay and all that stuff. And as a medical student, you try not to think about it too much. But it can get to you. Like it does at one point make you feel a bit uneasy, especially when you start thinking about, um, prepare like trying to get research opportunities or, get involved in stuff and going to conferences and presenting. It having like seeing those things on the news constantly and having those worries definitely does like take some toll. But I guess it's also motivating because it does like kind of push you to start preparing for those things earlier. Um, and yeah, that's mainly kind of my like evaluation of medical school. Um, Sorry if I've rambled on a bit. But I'd say like now is an opportunity, like if anyone has any questions, I feel like that will probably be more useful. I'd love to answer those. I think have people put it in the chat.
Yeah,
Oh
thank you
yeah.
so much, Sajida. I'm going to just answer like tell you the questions from the chat so then you can just focus on answering and not
Yeah.
reading the questions. So what supercurriculars did you do to expand your interests in medical school? And maybe they're trying to ask like how did you get into medical school and like what curriculars you did for that?
Yeah. So I think with me, I'm always like I'm quite an extrovert person. I like getting involved in stuff. I really like teaching, kind of like so for me, I never actually did those things for med school, but it ended up being very useful anyways. So in secondary school, any kind of leadership position I applied for. So I think at one point I had like 15. So like, all the like ambassadors and the prefects and senior prefects and deputy head girl team. Um, I did all of those because I genuinely just enjoyed those. Um, and then in sixth form, it became a lot more medical oriented. So I was on the medical society, my sixth form medical society, and then I kind of created like a sub section of that. So I created my sixth form's Oxbridge Med Support Group. So for people who are applying to Oxford and Cambridge and other selective universities, we'd kind of get together, talk through our applications, talk through kind of common interview questions. So that helped a lot. Um, Another thing, yeah, so and just kind of like being as involved in the community as possible because I think, yeah, for me, I just genuinely like doing stuff. I did a lot of like volunteer tutoring as well. Um, Kind of basically any opportunity that might came my way, I do. Um, so yeah, that was my that's like kind of like my short answer, I guess. But like students who are like interested in medicine and want to do so super curriculars, I say yeah, like try to get involved with any opportunities at your school, but don't feel limited to just your school. There are stuff outside of your sixth form and your school that you can get involved in. Um, even organizations like the Aspiring Surgeons Network, like this is such a cool thing. Like stuff like this is so cool to get involved with. And it's not necessarily like based in your sixth form, but it's stuff that looks really good. Like it does show your dedication to medicine. So yeah.
All right, thank you for that. Sajida, please, what resources and approach did you use to study for your UCAT?
Okay. So UCAT, I used, I think what's it called? Medify? Yeah, I used Medify. I think like all of my friends either used Medify or MedEntry at the time. I don't know if those are still like the top two. Then it was like those were the top two that people would use. And obviously we did the BMA as well, but obviously I know that's not really um a thing now. In terms of like my revision, I didn't actually do a crazy amount, although I would recommend doing more. I think I got quite lucky in my exam. I kind of did the whole of the summer holidays. I kind of on and off did UCAT prep on Medify. So every day I do like an hour or two on there. Um, and yeah, I think one thing that I really focused on, luckily, I'm a very fast reader, but during that time, I really, really tried to like increase my reading speed even more because you genuinely, it's like, I think more than anything else is the most valuable like thing to prepare for the UCAT because so much of it is just speed. Um, and also like the number one tip I'd give is please, please, please don't be afraid of skipping and guessing because you do not want to waste time. I think for me, my quantitative reasoning, I probably skipped 90% of that. Like I literally just guess and skip most of it. But I still did decently well because I know that it would have wasted my time if I stood there like trying to work out every single question. So increase your reading speed. Don't be afraid to skip. Essentially, just it's time is your biggest enemy with the UCAT. So kind of optimize that. Yeah.
Does BSMS follow a traditional medical course?
Um, I don't know so much about traditional because I'm not really sure. Like, if you asked me this question when I was in first
I
year, I'd probably be
think
able to answer it. Yeah, go on.
sorry, I think they're referring to like Oxbridge courses, so like if it follows the same trajectory as that.
Mm, I think it's not too different. So essentially, our first and second year, I think we have a little bit more clinical exposure though. Our first and second year is preclinical, which I think is kind of the same. Yeah. First and second year preclinical, like I mentioned, only 1 day of clinical. And then year 3, 4, and 5 is clinical. Only thing is we don't have compulsory intercalation. So you can intercalate if you want to, but it's a 5-year course. Um, One thing people are always interested in asking is dissection. So we do like cadaveric dissection in first year, and then in second year we pro sections. I think we're one of the only med schools that still do cadaveric dissections. And I actually really like the course at BSMS. We have a lot of clinical exposure. So um, yeah, I hope that answers your question.
I think Oxford and Cambridge do 3 years preclinical and then 3 years clinical, and then obviously an intercalation in between that.
Mhm.
So yeah, I think it's BSMS is like right in the middle of both types of unis. It offers
Yeah.
that middle ground. Um, what resources did you use for wider reading?
Um, for me, to be honest, I was like a major bookworm, so I'm pretty sure like I read any book that was like even remotely related to like medicine. Um, I didn't actually do much wider reading, to be honest. Like I read a lot of like, like This Is Going to Her and all those kind of books, like mainly just to kind of like know a bit more about what it's like working um like in a medical career. In terms of wider reading, I was really interested in like specific niche topics. Like at the time, it was like near just after COVID, I was really, really interested in mRNA vaccines. So I think I did a lot of reading around that, and I'd any kind of resources I'd find on that, I'd read. And I think also preparing for my Cambridge interview, I searched up the interviewers and like looked at like the kind of stuff that they were researching, and I low-key found those things really interesting too. So then I kind of would go down rabbit holes like researching those topics and reading them. So honestly for me, any topic that I like saw maybe in the news that I found remotely interesting, I just search about if there were any kind of papers. Obviously I would not be reading whole papers in year 12 or year 13, but like just reading the abstracts, be like, oh, this is kind of cool. um Kind of, yeah, anything. Newsletters, I signed up to quite a few newsletters. I don't really remember them now, but quite a few like medical related newsletters as well, which were kind of easier to read and stuff. Yeah.
I have a question. What was your EPQ on?
Oh yeah. So like I mentioned with the mRNA vaccines, I found them really cool. So my EPQ was on whether a vaccine mandate um was like an effective way to deal with COVID, and whether it would like essentially whether a vaccine mandate would have been warranted or not. And kind of just going into that.
Oh,
Yeah.
that's really cool. Yeah, because that is one of the like hot topics, if I'm not wrong, for interviews.
Yeah.
They like to really ask about that. So I guess that really might have helped you. One more
Yeah.
question, like upon reflecting on your rejections from like universities, what was the reason for your rejections, do you think, especially for like the University of Nottingham?
Yeah. So my GCSEs were mostly eights, and then I had two sevens and two nines. But with Nottingham and Case Kings, they were both pre-interview rejections. So I didn't get to do interviews with them, and they were both UCAT UDs at the time. The other two were BMAT. So for me, I didn't actually know exactly what the reason was. For KACL, I think I might have narrowly missed their UCAT cutoff, maybe. Although at the time my UCAT wasn't considered bad, so I think it was like in the second highest category. So I think it may have been my UCAT. Um, I'm not sure what else because I did have like the predicted grade. So maybe either my UCAT or maybe yeah, they were just better applicants than me. Nottingham, I think it was my GCSEs. Um, I think that year there because the year before me is like when it was a COVID year, so there was a lot of like backlog. So I think they raised their GCSE standards from what I know. So I think I didn't quite beat it, but I'm not actually sure to be honest, because obviously like they were pre-interview rejections, so I never heard back from them. But it could have been either my GCSEs or my UCAT. Yeah.
All right, thank you. Do you have any advice for getting the grades you need for medical school?
Yes. One thing is always like starting early. Um, and studying actively. I know this is probably like everyone tells you, forget about the reading your notes and highlighting your notes. It doesn't help. I think the number one thing I always did is revise the same way that you get examined. So if you're getting examined with exam questions, then your revision should also be exam questions. You know what I mean? What I would do is I'd literally go through a topic, watch some videos, really try to understand it, and then I'd literally just do as many exam questions on that topic as possible, mark them as harshly as I could, because then that's literally your minimum. Then you'll know your minimum, which means you can only do better than that in your actual exam. Mark them as harshly as possible, and then I'd all of the stuff that write down as my feedback, I'd turn into like flashcards, and then I'd go over those things. And that way, I knew I was only really studying the high yield stuff that would actually come up in exams. And for maths, yeah, just questions after questions after questions. Yeah.
All right, I think those are all the questions the audience has for you. And I guess any like last minute advice for people that may be having some sort of like difficulty in imagining themselves in like medical university and like just like I guess they're struggling with the fact that they might actually have the potential to get in. Do you have any words of advice for people like that?
Yeah. Oh, sorry. Yeah, I'd say don't let anything put you off. There's no such thing as a model medical student. If you've been into any hospital and you look at the doctors, none of them are the same. They all think differently. They're all different people. They all come from different backgrounds. Um, you don't have to be like super amazing, like the most academic person. You don't have to be like I don't know, like crazy confident. You can be shy and a really good doctor. So don't ever kind of, first of all, don't compare yourself to other people, but don't ever like tell yourself you can't be. There's no specific set of criteria that makes like the model doctor apart from, being empathetic, wanting to be a doctor, having that passion, being hardworking. Other than that, there's no specific criteria that says, oh, this person would be like a great doctor and this person wouldn't. So don't ever like think that you can't work hard. You do need to be hardworking to be a doctor, or to be a medical student. But yeah, just try your best. And don't put yourself in a box. I think a lot of people who apply to medicine tend to put themselves in this box and they think, oh, get into medical school, I need to be this and this and this and this and this. But you shouldn't like I think yeah, you shouldn't lose yourself, I guess, in the process of applying. A lot of people I know during first and second year, they kind of lose lose their hobbies, they lose everything they're interested about because they're like, oh no, like this is the only thing, like I just need to be model medical student. But at the end of the day, like the best medical student or the best doctor is the one who's well-rounded, who has other interests, who has other things going for them. So don't lose any of that. Just be yourself. I know as cliche and cringe as that sounds, be yourself and don't like ever think that you're not cut out to be a medical student or a doctor. Yeah.
That was actually really encouraging, and I'm sure like all the other audience found that encouraging as well. But yeah, that is all we have from Sajida, unless she wants to add something else. But yeah, thank you so much, Sajida, for coming on for this guest speaker event, and I hope you enjoyed it. I hope you found it enjoyable to talk to people and I guess share your experience. But yeah, I'll be sending you a feedback form later, maybe after the seminar, and then I would like you to fill it so then we can make other guest speaker events just a little bit better. But yeah, we'll be moving on to the neurosurgery quiz. So yeah, again, thank you so much, Sajida. I can't like actually thank you enough for coming up and yeah, just doing the guest speaker seminar because it was very interesting.
No, thank you. And thank you everyone
Yeah,
else as well
thank
for
you very
listening to
much.
me. And sorry for joining from a car. But yeah,
Yeah,
thank you very
thank you so
much.
much.
Yeah, goodbye.
Bye. All right, so we'll move on with a neurosurgery quiz. I want as much engagement as possible from the chat. And yeah, let's get started. So starting off with the easy question, sort of. What is the primary function of the brain? A, store calcium, B, pump blood, C, produce hormones, or D, control and coordinate body functions? So I'll give you like about 30 seconds because this is a relatively easy question. Okay, everyone's saying D, and yeah, that is correct. Quite rightly so. Now this one, what part of the brain is responsible for thinking and decision making? So is it A, cerebrum, B, medulla, C, brainstem, or D, cerebellum? Again, 30 seconds. Okay, we're getting a couple A's, and that is correct. Obviously, the cerebrum, I have a diagram here. So the cerebrum is like the main part of the brain. It's the largest part, and it is divided into six lobes, and one of them being the frontal lobe, which contains the prefrontal cortex. So the specific area in the brain which is responsible for thinking and decision making is the prefrontal cortex, which is located in the cerebrum. So, the six lobes that I was talking to you about are the frontal lobe, which is responsible for like reasoning, planning, and problem solving. Parietal lobe, which is involved in processing like sensory information. Temporal lobe is associated with memory and auditory processing, so that is like sound and hearing. Occipital lobe is primarily responsible for visual processing, so that is connected to the optic nerve from your eye. And insular lobe plays a role in consciousness and emotion, and limbic lobe is involved in emotion and behavior and like long-term memory. So those are the six like main types of lobes that form up the cerebrum. All right, next question. Which part of the brain controls balance and coordination? Oh, sorry. A, hypothalamus, B, pons, C, cerebellum, or D, thalamus? All right, quite a lot are saying cerebellum, and that is correct. So this is that part of the brain which controls like movement and coordination and balance. Okay, what are the grooves on the surface of the brain called? So are they known as gyri, B, villi, C, sulci, or D, fissures? If you're not sure, then you can just obviously guess and we'll go over the correct answer. So you will be learning in a sense. Uh, but yeah, 30 seconds. All right, quite a few are saying C, which is sulci, and you guys are right. So here again, these are the lobes that I was talking to you about on the previous slide, and so this has the four out of the six lobes because the other two are like I guess smaller, and these ones are the bigger sections. And so sulcus is what we were talking about. They're the grooves on the surface of the brain, so the squiggly lines here. And the gyrus is basically the ridge. So the thing that is like the fold that is formed between the two clefts on the cerebral surface of the brain. So this is obviously the cerebral surface. And fissures are a deeper groove than a sulcus and often separate like major regions of the or lobes of the brain. So here, like this is a major fissure and it's separating the left and right hemisphere. And fissures are can be thought of as like large sulci that have a more significant impact on the brain structure. So it's kind of like separating the brain's parts. Which fluid cushions the brain and spinal cord? A. Blood plasma. B. Synovial fluid. C. Cerebrospinal fluid. Uh, or D. Perilymph. 30 seconds. Not gonna lie, guys, you guys are on fire. You're doing this really well. So yeah, it is CSF. And so I just wanted to go over some of the main functions of CSF because you'll see that a lot with like neurology and neuroanatomy because CSF, again, it's in the name, it forms, it's the fluid that kind of roams around, circulates between this cerebral part of the brain and the spinal part of the nervous system. So essentially, the main functions of CSF is cushioning and protection, nutrient delivery and like waste removal, and homeostasis. So in one of our previous seminars, we went over blood-brain bleeds, and we talked about the Monroe-Kelly doctrine. And basically, what that means is the volume that the cranial cavity, so like your skull, can kind of hold is constant. And there are obviously three main factors. It is the brain itself, like the volume of the brain, the CSF, and blood in your brain. So if let's say because of a brain bleed, also known as a hemorrhage, if that like brain volume increases, the other two need to go down because there is only so much the skull can hold. And if that doesn't happen, then obviously there's an increase in intracranial pressure, which starts to affect the structures of the brain. And that's why it is a problem. That's why hemorrhages and like brain bleeds are a problem, and that's why they need to be drained. So then, obviously, it doesn't cause damage to the brain. And another feature and function of CSF is immunological protection and buoyancy, which essentially is like it allows the brain to kind of float within the cranial cavity. And yeah, so next question. So now we're going to be moving on to like some ethical scenarios. So here we'll be presenting some of like, I guess, scenarios and I want like longer form answers of stuff that you would be considering to say in an interview if this was an interview question. And then after that, we'll be going over some of the key points you should have included in your like question. I mean, in your answer. So yeah, a new robotic neurosurgery system reduces, sorry, reduces, I can't really see because, okay, reduces recovery time by 50%, but it is only available in private hospitals. So the ethical question that I want you guys to answer is it ethical to develop life-saving technology that only some people can access? So obviously this is an ethics-based question, so you might need to be thinking a little more. So if you're comfortable, you can like just move like turn on your mic and just start speaking at me. Or you if you can if you want to, you can do it on the chat. But I'll give you like 1 or 2 minutes for this. All right, we have some answers coming in. So, one of the answers says it only becomes unethical if the technology is made with only certain people in mind and without the goal of making it accessible to everybody in the future, which, yeah, I agree with. And another one says, I think so. By first giving it to some people, there's a better chance that in the future it will be accessible to everyone as there will be new ways to make the technology cheaper as time passes. So yeah, kind of just coming off the first point, waiting for a couple more because I do see some people typing. Why don't you guys try to give me like a counterpoint that you could, because obviously in an interview, if you're unsure of a question, you can't really just say one opinion, one side of the opinion. You do need to make sure that it's kind of balanced if you don't really have an opinion. Okay, another question. I mean, another answer is life-saving treatment shouldn't depend on wealth or insurance. Many ethical frameworks, like the NHS values, emphasize equal access to care, and it can reinforce like social inequality in health. So yeah, this is a fair point. This is, I guess, kind of opposing to what the other first two said, but I guess both of them are right in their own respects. Um, Okay, last one. It is not ethical as ultimately this goes against justice and as everyone cannot receive the same health benefits. However, over time, there could be adaptations to make the innovations more widespread and accessible. So yeah, I agree with almost all of them. I actually agree with all. And so yeah, some things that you can mention, which most of you did, is healthcare disparities, ethical pillar of justice, so the NHS values, and equity. Basically, every patient has the right to be treated equally, regardless of their wealth or, I guess, socioeconomic status. But yeah, obviously, most of the like treatments, not even just, robotic neurosurgery, just in general, there are many types of innovations happening that are only available in certain countries, like the high income countries that can afford the medication or the surgery type of like tool essentially. Um, and so yeah, it will take some time for it to kind of get widespread. So I guess you could talk about this in like in terms of vaccines because that is a very important point. You could discuss that like the higher income countries would have access to them first because they would have they're more likely to be making them or have the actual resources to be making them. So you could link that to the COVID vaccines or even this. So I guess both of them are correct, but I would suggest that you give like a more balanced approach to both, the good and the bad, essentially. So you talk about the healthcare disparities and also the fact that almost everything that is medical or tech related kind of first goes into the healthcare, like high income countries, and then it kind of comes down and gets accessible to the lower income countries. But yeah, that's not really fair in my opinion. But that's just, I guess how the world works. So, talking about the, I guess, issue with accessibility could help with kind of showing that you're grounded and you're not just like, oh yeah, like, I guess more euphoric about the idea that healthcare disparities don't really exist because they definitely do. Okay, another scenario. To train an AI system, a hospital decides to use thousands of previous MRI and CT scans from patients. Some patients were never asked for permission because the data was anonymized. So the ethical question is anonymized patient data enough, or should explicit consent from patients always be required? So obviously these are probably past patients and present patients. So would it affect if they were past patients or not, basically? Again, I'll give you like 1 or 2 minutes so you could write the answer down. Also, one thing I've noticed is if you obviously do interview questions, one of the really useful things is having examples, like real life examples that you could include. So this is why it's really important to read on like hot topics. So previously, I mean, we're gonna start doing it again after the neurosurgery seminars, but we used to have like case studies of specific patient cases that are like well known in medicine, and they're usually based on like ethics and like hot topics such as vaccines. And so I guess having that type of like wider knowledge and like more specific knowledge, in fact, would be very beneficial to, I guess, show the interest that you have for medicine. So now we have some answers, so I'll go over them. Um, Explicit consent should always be required. There might be specific cases that makes it really easy to identify who the patient is, so I don't think it is fair on the patients. All right, fair point. Patient should always be prioritized, where we should respect the patient's privacy. To be honest, anonymization should be a standard treatment of means, but consent should always be required to begin the process of using data in the first place. All right, that's a good point too. Third one, explicit consent should always be required as data in the MRI and CT scans can hold personal value to the patients and make patients feel uncomfortable if shown to someone else. These scans are also confidential, so permission should be asked for before. However, these scans can help educate others about uh, their health, showing its benefits. So yeah, I guess that is also true. I guess we're waiting on like one more answer. I think we should always aim to maximize patient confidentiality by protecting patient data. But if a patient explicitly states they don't want their data shared, the it is not fair to still use it even if it's anonymized. However, there can be some cases where the patient isn't competent enough or able to like provide consent. In a situation where consent can't be given, patient data should always be optimized. All right, so these are really, really good like answers. And so these are some main things to mention, which I think everyone has mentioned in their answer to some extent. So confidentiality, ethical pillar of autonomy, right to withdraw, and informed consent. So these are obviously really, really important things. I don't think many people talked about autonomy. I would suggest that when you look at these type of ethical questions, you base it on the first thing you base it on is the four medical principles, the four ethics, like pillars of ethics, because that is, I guess, the most important thing to consider because they are the pillars of ethics, right? And so most of them include, like justice, autonomy, non-maleficence. And if you want, we could do a seminar specifically on them if that's interesting to you. Like, please do suggest that. But yeah, something else you could have considered is the fact that AI is actually like rising in healthcare, and it is benefiting a lot of people, a lot of like patients, and obviously robotics and AI and the use of that is rising in medicine. And it will help patients in the long term because it will help with like diagnosis, because obviously we'll have like a second brain that will help reduce human error. So that might actually be helpful for the patients, and future patients and their prognosis. So you could have taken it to like a like completely different perspective, and that shows that you really have like a well-grounded argument in a sense. So you could have considered that too. All right. A patient is harmed during an AI-assisted neurosurgery. The ethical question is who should be held responsible? The surgeons, the MDT treating the patient, the hospital trust, or even the AI developer? So what do you think? This one's actually quite hard because I don't know what you guys think, but I would say this is a really hard and mean question to be given. But yeah, just your thoughts. 1 minute. Uh, So someone asked, what does MDT stand for? It's a multidisciplinary team, and that basically means like all the type of like medics, so from different specialties. So maybe like anesthesists, neurosurgeons, and like I guess just nurses, like surgical nurses. So all of them kind of working together as a team, multidisciplinary team, to kind of help with patient outcomes and work through a surgery and like pre-op and post-op. So that's what an MDT means. Okay, we have a couple answers. I think it depends on what kind of error was made. For example, did something go wrong when the surgeon was operating, facilitating the surgery, or was it clearly a mistake by the AI? I think the people operating or who were in charge of AI technology at the time, when the patient was harmed, should be held responsible. So yeah, these are good points. Obviously, um, there are many like harmful things that could happen to a patient. Like obviously there are many complications that could rise during the surgery or even after the surgery. So it kind of depends on what happened in the situation. So yeah, Ellie is kind of right to raise that. And the hospital trust as they're in charge of the of approving the use of AI in neurosurgery. Um, so yeah, that is also a very good point. Another point that was made is I think this is a hard question, but it says that AI assists with the surgery. So if AI played a minimal role in the surgery, which just so happened to cause damage, the MDT could be held accountable for allowing the use of the AI assistance if it still could have been done without it. So yeah, again, great points. Some things you could have mentioned was collective responsibility, duty of candor, which is a ethics-based principle, which basically kind of means when there is something that goes wrong, if there's like a crisis or a complication with a patient that was caused by the healthcare, like the hospital or healthcare staff, then you must be open and honest to the patient because they have that right to know what happened to them, even if that means that it was your fault and you have to own up to it. And another thing you could have mentioned was professional duty. So yeah, these are all true statements. But I guess talking specifically about like keywords like duty of candor would really help with showing the interviewer you really know what you're talking about. But yeah, I mean, you need to consider the type of like context this happened in. And I feel like thinking and questioning the question and kind of just I guess thinking outside the box would actually help with your Oxbridge interviews. So I would consider if you're applying to Oxbridge, you start thinking a little bit like that as well. But obviously, MMI interviews, they don't really mind that much about what you're thinking. They just want you to say the, I guess, keywords. Like there is a way you could cheat in the system, I guess. Um, Obviously, we're over the time, so if you guys are still interested in doing this, like continuing it, if you could you like react with like a thumbs up or whatever, so then I know that we can continue, and if not, we can obviously like do this next week as well. I'll just be waiting. Wait, sorry, I don't think yeah, anyways. Do you want to continue the session or do you want me to like end it now because it obviously has run out of the time? All right, I guess like we do want to do it. So yeah, duty of candor is basically a ethical principle, which basically means that if something happened to the patient, like a complication or like a risk, like something that happened to the patient because of the healthcare treatment they received, or maybe the like a mistake from the hospital or healthcare professionals, then it is you need to be open and honest to them about the situation and kind of own up to your mistake. Because okay, for an example, um, this is obviously a wild example, but um, one of the surgeons, they operate on the right hand of your arm when they were supposed to on the left. So obviously that is a really big issue because they completely messed up your surgery and just operated on a hand that was working fine. So obviously for that situation, you kind of need to be open and honest about the mistake and kind of own up to it. Obviously, this is a very extreme case. I don't know why I thought of that, but yeah, that's just like you need to be open and honest with your patients, even if, like, I guess because they were harmed, you need to be telling them that it was because of us and we will do this to kind of solve it or to mitigate the risks. Yeah, so we'll move on to another question. This is again ethical based. A hospital uses AI to decide which patients receive surgery first, so like priority, based on predicted recovery time or reduce to reduce long-term costs. So the ethical question is, should AI be used to prioritize patients based on efficiency rather than the clinical need? I think this is quite an interesting question. Could go a lot about this. This has a very big scope. So I'll give you like 1 or 2 minutes. I think we'll make this the last question. And then we'll save some of the other questions we had. Like I think we had like maybe three more, 3 to 5 more, and then we will just do them for the start of the session for next week. Because I do understand that this is obviously going over the time. But yeah, I'll send in the attendance form soon after going over this question. And then yeah, we'll call it a day. Okay, we're getting a couple answers. So one person said clinical need. Some patients may be in a more critical condition, which requires more urgent care. If medical attention isn't provided, that the patient could end up in a more critical condition. If basing on efficiency, many people may not be able to be given the medical attention that they require. This would essentially ruin the efficiency. Um, I think AI could be used to prioritize efficiency, but not for the reason of reducing long-term costs, rather than rather because of the really bad wait in NHS waiting time. And if the AI can be used to make hospitals more efficient, then more people could receive treatments in the long term. So yeah, I guess these are good ideas to be considering. So things you could have mentioned is utilitarianism, which is basically a philosophical like idea where it means that if you do something is right if it's benefiting the most people. So the most amount of people. So if like AI has been installed for neurosurgery, and obviously let's go back to the previous example. If it's installed and it needs like thousands of CT and MRI scans to be fed to it so then it can learn the algorithm, then like this ethics principle, utilitarianism, would say that it's like it would be right too because it's gonna benefit a lot of people in the future with like diagnostics and just, I guess, getting their treatments ready. So that is what it means. If you want more clarification, we can go over that. An ethical pillar of justice and purpose of healthcare professionals and NHS. So obviously, you don't want AI to kind of overtake like medical like knowledge, because obviously healthcare professionals have literally studied for their whole lives to be able to come to a position where they can make medical judgments on specific cases. And obviously AI, if they're just looking at the predicted recovery time, the patients that need it the most, they kind of like they don't get attention, and they won't be able to get the treatment that they need critically. And obviously AI is going to miss that empathetic kind of perspective that the human elements could add. And so yeah, you guys are completely right. I would say, in my opinion, that it wouldn't be the best thing to use AI for. But yeah, I guess we'll wrap it up here. And I'm gonna send in the attendance form. It would be amazing if you could fill it out. Um, and yeah. If you have any questions about the things we discussed, or maybe I guess some feedback or any suggestions of like next type of like seminars we could do, or something that would benefit you, then yeah, please go ahead. Another I guess answer is I feel like AI would also have an educated judgment rather than looking at emotional aspects of considering within the patient. Yeah, exactly, just what I touched upon. It would also be better towards patient care. Yeah, exactly. Obviously, AI is just an algorithm. It doesn't have the human compassion or empathy that it kind of needs to be able to um, like decide which patient needs what first. So yeah, I do agree with that. So yeah, thank you guys so much for joining this week's seminar. I hope it was helpful for you guys. And yeah, so from next week, we're going to continue with the neurosurgery um, seminars, and we'll be talking about like, other neurosurgical um, like fields stuff. So yeah. Um, f- a question for these types of ethics questions in interviews. I know it's a good to have a counter argument, but should you still have a final answer? Yes, you should, because you don't want to seem iffy jiffy with your answers. You need to have some sort of inclination to one point. Basically, the answer structure that I think is the best um, is to, I guess, kind of think about the fact that you need to give a for and against and then your opinion. So give reasoning for both and then choose what you want as your answer, as what you resonate with the most, and then give a reasoning as to why. Especially in MMI interviews, that is really important. I think panel interviews, like for Oxford and Cambridge, they tend to really focus on um, like what you think and like how you process the question, instead of just kind of spitting at them facts. That's what they want. Is there a code to join the Teams group chat? We don't have a Teams group chat. We just have the WhatsApp organization community page. So that's where you can get all the updates. Um, and yeah, is there a certificate for after if you attend like 5 seminars? Yes, there is. And if you've attended all of our neurosurgical like seminars, we will also be giving you a certificate just for that, because obviously if you attended neurosurgical series specifically, it will help show your interest in neurology, neurosurgery. So it will be really helpful for your personal statement and also just general knowledge. Because yeah, you could be asked these type of questions. So yeah, I hope you guys enjoyed this. And yeah, if you have any questions, I'm here. I'll answer them for you. Thank you very much.